Good day. My name is Jake Van Dyke. I'm a Professor Emeritus of Western University in London, Ontario, Canada, and founder and former president of Medical Physics for World Benefit. This presentation is for the course that's being organized by Carlos de Almeida, entitled High Technology in Radiation Oncology, and it's being presented in Brazil in voltage treatment technologies for radiation oncology. And I have a couple of disclosures. One is that I have a license agreement with Modus Medical Devices in London, Ontario, Canada for Quasar QA tools that are marketed by them. I also have a more recent book that has been published in June of 2023. It's intended for a broader audience, so it's written at a level that is more understandable than the normal language we use for medical physics and radiation oncology. It's stories from a series of high-profile medical physicists, and it's intended to describe medical physics to a broad audience. One of the chapters in that book is also written by Professor Carlos de Almeida. And by way of introduction, in this presentation, I'm talking largely about contents of the modern technology of radiation oncology, with the subtitle of Compendium for Medical Physicists and Radiation Oncologists, Volume 4. This came out in 2020. It's volume 4 of a set of 4 volumes that all tie in with the modern technology of radiation oncology. The first volume was 1999. It's obviously the biggest. It contains all of the technologies that were in existence at that time, written up in some depth. And then volume 2 came out in 2005, and it contains the advancements that had taken place between 1999 and 2005. The third volume came out in 2013, and then this last volume in 2020. And this presentation is largely on chapter 1. And the title is Technology Evolution in Radiation Oncology. The rapid pace continues. But it's really an overview of what happens and what is presented later on in the book. So the objectives here are to review technological developments in radiation oncology, all in the past, present, and future, to review some of the data on the benefits of radiotherapy, and to provide some specific examples of evolving trends. So here's a graphic that I have generated, and the curve is largely a figment of my imagination. It shows some trends, and they're quite plausible trends, but in reality, the curve is my imagination. And on the vertical axis, I have clinical benefit, and that could be survival from treatment for formality.
Dr. Hamza, is everything okay?
It doesn't, it stopped for me.
Just a minute.
Those distributions were not terribly uniform.
Yeah.
It's hung up again.
Sorry for this intermittence, but will be solved soon. Dr. Hamza, are you okay?
Use of cobalt-64 radiation treatment. And then we also got into linear accelerators that came out within a few years of cobalt-60 being implemented. And this meant that we were able to use megavoltage X-rays or gamma rays. We had some skin sparing. We had more uniform dose distributions. At that time, computers were not yet available, and treatment planning was done manually, summing isodose distributions and taking into account skin surface and making contour corrections. Then we got into the 1960s and 70s. Multi-energy LINACs were available. Computerized treatment planning systems were developed, and simulators were, and these were conventional simulators. Simulators were made available commercially. In the 1970s and 80s, we got into CT scanning. CT scanning was developed in the 70s, and it became available for radiation therapy planning towards the late 70s. And we had CT and 3D conformal radiation therapy, brachytherapy afterloading systems. This little picture here is a picture of me in 1980, and I'm sitting behind a CT planning workstation and doing some treatment plans for patients. Then we got into the 1990s. Intensity modulated radiation therapy, image-guided radiation therapy, adaptive radiation therapy, positron emission tomography, magnetic resonance imaging and image-guided radiation therapy combined, protons, carbon ions. So many technological developments and implementations occurred during those period of time. And then, of course, the question is, well, what's next? Where do we go from here? And now you can see that this graphic that I've drawn, it looks like there's an improvement in survival or an improvement in conformality with time. And the reality is that there's only two real data points that I have on this graph. In the 1970s, the overall survival, the 5-year survival for cancer patients was about 50%. In the 2010s, the overall survival was about 67%. So there was a marked improvement in the overall survival. And these are based on real data. And I will show you these data in a couple of subsequent slides. So here we have data from the United States, 5-year survival data. And the reddish points are from the 1970s. The bluish points are from the 2010s. And you can see here, for all cancers, there was a 50% survival in the 1970s and a 67% survival in the 2010s. And so this is based on the surveillance and epidemiological data and end results program from the United States. So what we see here, that all the cancers that are listed here improved, except for cervix and uterus. They actually declined. Now, this is a matter of how the data is captured. They point out in the article that there's a lack of major treatment advances. And in cervix cancer, there was an increased proportion of adenocarcinoma which had a lower survival rate. So the patients that were diagnosed with different types of cancer, and that in fact resulted in an overall lowering of the survival. But for prostate cancer, we see that it went from 68% to about 99%. And for all the other cancers, we can see leukemia, for example, 34% went to 61%, and so on. We can look at all the others, but there's improvements in all the other cancers. The reason given in the paper was related to early detection and improved treatment. Here's another set of data. These are age-standardized 5-year survival data for 7 high-income countries. And the data range from 1995 to 2014. So these were the improvements that were shown over that period of time. And you can see that if we look at, this is esophagus, for example, and we look at the different countries here, and that there is an overall improvement in all of these. And then we can see that for stomach cancer, for colon cancer, for rectum, for pancreas, lung, ovary. And the countries involved are Australia, Canada, Denmark, Ireland, New Zealand, Norway, and the United Kingdom. There are some international disparities, but again, the reason given: earlier diagnosis, improved treatment. So why are we getting these types of changes? The hypothesis is, for the use of these new radiation therapy technologies, is that more accurate dose delivery and better dose distributions yield better clinical outcomes. The basic strategy is to reduce the treatment volume and irradiate smaller volumes of normal tissue. So here we have the ICRU definitions of gross tumor volume, clinical target volume, and planning target volume. And the planning target volume is that margin that's given around the clinical target volume, such that we make sure that when we treat on consecutive days, we're always getting a high dose to the clinical target volume. Now, if we are able to reduce the clinical target volume, as is shown here, then if we're able to reduce the planning target volume, as is shown here, then we are able to reduce the amount of normal tissues that are irradiated. And this allows for a higher dose to the tumors and reduces the normal tissue toxicity and increases the tumor control probability. So now let's look at the technology evolution in radiation oncology. And these are largely the chapters that are in this volume 4 of the Modern Technology of Radiation Oncology. Surface guidance technologies, hybrid PET and MRI for treatment planning purposes. And where I've got LECT here as a superscript, these are other lectures in the course that is being given in Brazil. Stereotactic body radiotherapy, real-time image guidance with magnetic resonance, robust optimization, and where I have an asterisk, these all relate to artificial intelligence. Automated treatment planning, artificial intelligence in radiation oncology, adaptive radiation therapy, machine learning, big data, radiomics, update on RBE for particles, high-Z nanoparticles, technologies for improving access, flash radiotherapy. And then there's several chapters that deal with financial economic issues and global medical physics issues. And so these are largely the contents, the topics of the chapters in this book. Note that of the 18 chapters, 7 of them relate to artificial intelligence. So artificial intelligence is a big deal in the use of the modern technology of radiation oncology. It's about 40% of the contents of this book. I can only touch on a few of the topics. A 1-hour presentation does not allow for getting into details on all of these topics. So I will only give an overview and touch on a few, and from a fairly light and superficial perspective. The topics in red are the ones that I will be addressing in this presentation: surface guidance, real-time image guidance with MRI, robust optimization, automated treatment planning, and flash radiotherapy. So looking at surface guidance in radiotherapy, we use an advanced 3D camera system to track the patient's skin surface. So the camera system is such that it generates a 3D image of the patient's surface. And you can see examples of this thoracic chest camera display. So, and there's been a substantial increase in interest in this over the last few years. So if we look at the publications as found on PubMed on surface guided radiotherapy, we see that while there are a few publications starting already in 2012, it's really taken off since 2019, with a significant number of publications in 2022. What the system consists of is a 3-camera installation system. So if we look at the therapy machine, which is here, you can see the 3 cameras mounted from the ceiling and from a different perspective. This is a bit of a side view, and this is a direct view from the couch into the treatment machine. And we see that there's 3 cameras taking images of the patient. And then this is an example. It's a bit of a complex figure, but this is an example of daily treatment on a breast cancer patient. And the different colors represent different days. So you can see that there is a shift in the patient setup from day to day. And it really shows the variability in the arm position for a breast cancer treatment. So this example gives a significant amount of variation. So how do we quantitate that? Well, here's an example from the paper by Stanley et al. That gives a comparison of setups and the magnitude of the shifts to set the patient up and the frequency of them. So it's a histogram of the shifts to get a proper setup. If we use a 3-point laser setup, then these are shown in blue, and the surface image guidance system are shown in red. And we can see for pelvis and lower extremities that the histogram has shifted to smaller magnitudes of shifts compared to the conventional setup process. The same is true for abdomen. Again, we see the surface image guidance system has a histogram that is shifted to the smaller shift vectors compared to the conventional 3-point laser setups. Chest and upper extremities, similar trends. And then breast, the trends are even larger. So you can see for breast setups that there are significantly larger shifts required with conventional setups than there are with the surface guidance technologies. So here is a summary with the data being put into statistical form here for the pelvis and lower extremities, a 3-point setup on average, it's a 0.9 centimeters shift. And for surface image guidance on average, 0.6 centimeters. Abdomen, 1 and 0.5. Chest and upper extremities, 0.9 and 0.5. Breast, it's 1.4 and 0.6. So in terms of overall variations, the setup uncertainties with the surface guidance system are reduced by approximately a factor of 2. So we're in the neighborhood of 1 centimeter here. We're in the neighborhood of 0.5 centimeters here. And so there's a significant improvement in patient setups. Now, the next level of technology advancement, you might say, is real-time image guidance with magnetic resonance imaging. This is actually a picture of my grandson. And as much as I love my grandson, the point of this slide is the shirt that he's wearing. And I'm interested in this logo. You can't hit what you can't see. Well, in his example, it's for baseball. In our example, when we use real-time image guidance, we are looking at what's inside the patients so that we can hit what we can see. So the real-time image guidance with magnetic resonance, and then that evolves into adaptive radiation therapy. One combines an MR scanner with a treatment machine. So the example here is the Philips magnetic resonance imager is combined with an Elekta Linac, and the two of them give an MR Linac. So here's that system, an MR system with the Elekta Linac. And these are coils that are used for the magnetic resonance imaging part of this setup. So there's several organizations or companies that are working on magnetic resonance Linacs. Elekta is one, ViewRay is the other. Magnetex from Alberta is another company that's under development. And then there's a project going on with Paul Keel in Sydney, Australia as well. So with magnetic resonance imagers, we have magnetic fields, and there are some unique dosimetry effects that need to be considered when we're using treatments in magnetic fields. So because magnets are involved and any electrons that are set into motion end up having a curved path, the nature of which would not exist if there was not a magnetic field. So these are the electron paths in water, and they depend on the energy. So it goes from 2 MeV to 6 MeV, and it depends on the magnetic field. So 2 MeV and 4 MeV here at 1.5 Tesla. And these other ones with the lower magnetic fields, we have a lower bending of the electron paths, and depends on the energy and the magnetic field. And then these are the kernels that are produced in the patient. So if we have no magnetic field, a photon comes in, this is then a dosed kernel. This is how the energy is distributed when that photon interacts at that point. However, if the photons interact in a magnetic field, then we have a kernel that is shifted as a result of the impact of that magnetic field. So this requires that beam calibrations and dose calculations need to account for these magnetic fields. It depends on which way the fields are pointing. It depends on their strength of the magnetic field, and it depends on the energy of the electrons that are set into motion. So what have we got with real-time image-guided radiation therapy with magnetic resonance imaging? Well, we have sub-millimeter stereotactic precision. Because we can see the patient so accurately, we can do that even before we start treatment. And daily magnetic resonance image-based online plan adaptation is possible, so that we can adapt the plan based on the patient's positioning, both of internal and external anatomy for that particular day. And the other thing is that MR provides excellent soft tissue contrast, much more so than what we find with CT scanning. MR provides opportunities for functional imaging. So we get functional information about the tumor as well as the normal tissues. And this can then be used as part of the planning process. It can be used as part of the adaptive process. So, for example, we can see regional differences within the tumor volume, and these regional differences can be given different radiation doses. And this is what has been termed as dose painting. And we can also evaluate the regional functionality of normal tissues and plan the dose distributions accordingly, so that we might give lower doses to regions that are more sensitive to the radiation interactions. So I'm pleased to report that the work by these two people who developed magnetic resonance imaging, LINAC, they won the most citations in physics and medicine and biology in the preceding 5 years. And they're the two authors of Chapter 4 on magnetic resonance imaging image guidance. The lead author, Jan Lochendijk, and the other first author is Bas Rijmakers, both from the University of Utrecht in the Netherlands. And as I understand it, Bas Rijmakers will be giving a lecture in this course as well, that is in the Brazilian course. So this is also from the website from the Institute of Medical Physics, the Institute of Physics in the United Kingdom, and they summarized the debate that took place in the ESTRO meeting in 2020. And the question was, is the MR-Linac really the future of adaptive radiotherapy? So I'm going to review some of the points that were made, adaptive radiotherapy with the magnetic resonance LINAC. And the points that were made at this debate both addressed positive aspects and addressed some negative aspects as well. So first of all, it aids with hypofractionation. It can monitor biological response. It allows for functional imaging. However, the point was also made that adaptive radiotherapy can be done without an MR-Linac. It can be done with a Linac with cone beam CT. The time per fraction for a magnetic resonance Linac treatment is 50 minutes. The time for a fraction treatment with the ethos Varian cone beam CT system is 10 minutes. So there's a longer time per fraction for treatment with the magnetic resonance Linac. One person made the point that it's more important to define patients benefiting from ART, so that not all patients are treated this way, but only the ones that actually yield the clinical benefit from the process. There is a simple adaptation of workflow with the magnetic resonance Linac because there are defined steps in the process. And then there's a cost versus benefit issue that needs to be resolved yet. Magnetic resonance Linac costs 4 times the cost of a cone beam CT Linac. So the benefit remains to be proven according to that debate. However, I'm going to show you on the next slide some data that came out within the last few weeks. And then again, this is from the Institute of Physics website. They give a weekly report on medical physics related issues. And the title here is Magnetic Resonance Imaging Guidance Reduces Side Effects of Prostate Cancer Radiotherapy. And this was 17th of January, this was reported. And in a nutshell, this was based on a paper that was published recently. The technique is summarized here. Stereotactic body radiotherapy, both of them are stereotactic body radiotherapy. One is with CT guidance and one is with MR guidance. In both cases, 40 gray were given in 5 fractions, high doses per fraction, hence stereotactic body radiotherapy. The planning margin used for CT guidance was 4 millimeters, for MR guidance was 2 millimeters. So in other words, smaller volume of normal tissue was irradiated with MR guidance compared to CT guidance. They evaluated 100 patients. In fact, they stopped the study because they noticed the differences at a preliminary evaluation after 100 patients were treated, and each of them was evaluated at equal to or more than 90 days post-treatment. And this was the interim analysis. So grade 2, greater than or equal to grade 2 GU toxicity, the results were 43% for CT guidance, 24% for MR guidance. The results of greater than or equal to grade 2 GI toxicity was 11% versus 0%. And as a result of this interim analysis and these data, they closed the trial for further accrual. Their conclusion, and I quote here, and the reference is shown in the Journal of the American Medical Association, Oncology, and that was published in January the 12th, 2023. The conclusion, MRI-guided SBRT significantly reduced both moderate acute physician-scored toxic effects and decrements in patient-reported quality of life. Longer-term follow-up will confirm whether these notable benefits persist. So longer-term data are still awaiting, but short-term results make a clear indication that there are significant improvements by reducing the margin and using MR guidance. So this leads to the next topic, and that is robust optimization. And then this addresses issues related to uncertainties. And I know that Professor Carlos de Almeida is going to be speaking on uncertainties in radiation therapy, but this is an overview of the use of robust optimization to account for uncertainties. So we have uncertainties at various stages of the radiation therapy process, including delineation of targets and organs at risk. In fact, there are indications that these are the largest uncertainties associated with radiation therapy. There's a setup uncertainty, there's geometric uncertainties, there's motion uncertainties as a result of patient breathing. There are imaging uncertainties, both for planning and for treatment. And then there's dose calculation and treatment planning related uncertainties, dose delivery uncertainties. And then specifically, if one is using proton therapy or particle therapy, there's a uncertainty associated with the depth of penetration of the particles, whether they be protons or carbon ions. So the approaches to uncertainties are the following. First of all, we've already talked about margins. So the CTV to PTV margin, clinical target volume to planning target volume margin, accounts for these treatment-related uncertainties. But what's been developing over the last number of years is the use of robust optimization. And that consists of developing a treatment plan that is minimally affected by treatment-related uncertainties. So here's an example. Now this relates to proton therapy, but here's a patient that's being treated with proton therapy. We see two things on here. We see a nominal setup. This is the dose distribution that is obtained with proton therapy using a nominal setup. And then this is a shifted setup. And the shift that's incorporated in here, and this is a planning exercise, okay? But so we force a shift of 0.5 centimeters superiorly and a 3.5% change in density, an increase in lung density. And so this plan, when calculated on this shifted geometry, the dose delivery changes in that geometry, and the change is shown by the change in the color of this dose distribution. And we see a relatively large difference between the nominal setup, and if this shift in reality exists, then this is the dose that would really be delivered to the patient. Now, when we use robust optimization, we get a different, so this plan is now optimized to account for these kinds of uncertainties. And the plan is generated in such a way that it's minimally affected by those uncertainties. So we do get some difference between this plan and this plan because we've used robust optimization. But now when we look at this plan, compare it to that plan, then again, there is relatively little difference between these two plans, the nominal plan and the plan that accounts for the shift and the change in density. So robust optimization is less affected by the treatment-related uncertainties. And so that helps allowing a more uniform and a more consistent dose delivery to the patient. And so there's a fair amount of activity going on with robust optimization. It's become available on commercial treatment planning systems. And one can now ask the question, if we use robust optimization, do we still need to use the margin around the clinical target volume? Do we still need to use the planning target volume? And the question is, does that mean that we may no longer need to use the planning target volume? So let me now go to automated treatment planning. This is also an activity that's in significant research development. So we've used task level automation already by using some scripting routines that can automatically go through the steps in the radiation treatment planning process. I've got this graphic, by the way, on the side here, and it shows the complexity of the entire treatment planning process. So for treatment planning, we go through patient positioning and immobilization. Patient anatomical data are acquired with CT, MR, or PET. We use anatomical models to delineate the target volume and the normal tissues. We come up with a planning routine and go through plan approval and plan implementation, and then we go to treatment delivery. Now, all of this is the treatment planning process, and you can see the number of steps in it. And as I've said, we've already used the scripting process for that. Semi-automation can also be done with editing. For example, automated contouring can be done and has already been developed. Full automation with review is the part that's in active research today. And full automation without review, where you believe the full automation process, according to some authors, is not likely to be achieved for the next 10 years. So let me just address this automated contouring procedure. It uses deformable image registration-based techniques, and there's some deep learning, in other words, artificial intelligence that's used for the contouring process, and has become acceptable for treatment planning purposes. And so these are data on this side that are based on this paper, Retrospective Validation and Clinical Implementation of Automated Contouring of Organs at Risk in the Head and Neck, a step toward automated radiation treatment planning for low and middle income countries. Well, they talk about low and middle income countries, but it's also relevant to high income countries as well. And what we see on these graphics are histograms, and this shows a fraction of ratings. So these were rated by various people, primary physician rating here, and it shows if no edits were provided, 92% are accepted. With minor editing, 7% are accepted, and with major editing, 0.8%. So it shows that the automated contouring works well without editing for 92% of the cases for this brain tumors. For brainstem, it's almost 95%. For the cochlea, it's about 69% that are no edits, about 29% with minor edits, and about 2% with major edits. For eye, about 95% no edits. For lung, about 89% no edits. For mandible, about 97% no edits. Parotid, 93%, and for spinal cord, it's 100%. So what we're seeing here is that automated contouring actually can work quite well and is likely the way of the future in terms of the automated treatment planning process. And then this is work by Lawrence Court, who summarizes the steps in the radiation treatment process. And this is the conventional radiation treatment process. And then when you go to the automated process, actually the number of steps is dramatically reduced to the point that it's probably reduced by over 50%. So there's less than 50% steps in the process required with automated treatment planning compared to manual treatment planning. And then the time to generate a complex plan is published by this paper from 2013. For head and neck cancer, manual planning, it's about 4 hours or more. For automated planning, about 8 minutes. The anal canal, it was over 2 hours for manual planning, about 6 minutes for automated planning. For prostate with pelvic nodes, about 1.5 hours down to 6 minutes with automated planning. And so these are very significant reductions in the amount of time required to go through this planning process. So why do we need automation? Well, the obvious part is to improve efficiency. And so the reduction of time is clearly a benefit, but there are other benefits as well. It allows for improvement to access for high quality radiotherapy across the world. It provides improvements in quality and consistency. Since it's automated, there's less human judgment involved in the individual patients that are treated. So it improves quality and consistency in prescription and in plan design. And it improves safety. It reduces the number of treatment planning errors, and it allows for an increased detection of planning errors as well. So there are significant benefits to automation that go beyond just improving the speed by which the process is developed. So the last topic I'm going to address is flash radiotherapy. And this is now a topic that is of significant interest in the research circles. It's not routinely available yet, but it's something that we should look forward to in the future. And here's a graphic of the number of publications per year on flash radiotherapy. While it began already in 1988, the real increase has occurred in the last 3 or 4 years. And so, there's a very significant interest in flash radiotherapy. So what is flash? Well, flash uses ultra-high dose rates compared to the conventional dose rates. So here we have more than 50 gray per seconds are used in flash, and this is equivalent to 300,000 centigrade per minute. And we usually think dose rates in radiation therapy in centigrade per minute. And this is compared to 0.1 gray per second. So it's more than 50 grays per second compared to 1.1 gray per second. And our conventional dose rates on a linear accelerator tend to be in the neighborhood of 600 centigrade per minute. So there's a factor of 500 difference in dose rates. The dose rates for flash are 500 times greater than they are for conventional radiotherapy. And what's been observed is that there's normal tissue sparing, and this has been observed in preclinical models. So in other words, in animal models, lung, brain, intestinal tract, skin are the normal tissues that have seen some benefit from flash radiotherapy. And in some cases, there's also an enhanced tumor response. So, however, to get these dose rates that are 500 times greater, we need to have specialized flash technologies. And some of these that are under evaluation are using low energy X-rays. In Victoria, British Columbia, and Canada, they're using 160 kilovolts X-rays, again, for preclinical models. In Lausanne, they're using high energy electrons. This is Lausanne, Switzerland, and they're using 4 to 6 MeV electrons. In Grenoble, they're doing research on synchrotron X-rays of an average energy of 102 kiloelectron volts. A system is being developed using high energy X-rays. It's called the phaser system, and they're using energies of the order of 10 megavolt. Very high energy electrons have been proposed by the research group at CERN in Geneva, Switzerland. This is the European Nuclear Research Agency, and they're using electrons between 50 to 250 MeV. At the University of Pennsylvania, they're using protons, and these are 220 MeV protons, so the energy is consistent with the lower dose rate protons, but they've been able to develop beams that are flash dose rate beams. So here's some examples. This is from a paper by Vosinen et al., published in 2019, work from Lausanne, Switzerland, 6 MeV electrons. And this is mini pig irradiation. So this is the CT scan of the mini pig. These are the electron dose distributions. They're shielding blocks put just above the patient to show where these electrons go. And again, being 6 MeV electrons, they don't have a large depth of penetration. And then the example here is that they're using both flash beams and conventional beams. The dose is prescribed at a 12 millimeter depth. They've looked at the skin reactions 3 years post-irradiation. And here is what we see. At a conventional dose rate, 5 gray per minute, we get these kinds of severe fibrotic lesions showing up on the mini pig skin surface. For flash radiotherapy at 300 gray per second, we more or less see a normal skin reaction. So there isn't the severe fibrosis that we see with the conventional techniques. The first patient with flash radiotherapy was treated on the 7th of November, 2019. Again, it was from the Lausanne group. Jean Bourri is the radiation oncologist who is the first author on the paper that published this, as well as the radiation oncologist involved as a lead person in the FLASH program. And here what we see is the reaction at day 0 of the day of treatment. Here we see the reaction at 3 weeks after treatment. And here we see what it looks like at 5 months. And clearly there is a very significant lack of reaction, you might say, as a result of the FLASH radiotherapy treatment. So then there is a paper that was published in 2020, and the title is Ultra High Dose Rate FLASH Radiotherapy, Silver Bullet or Fool's Gold. So first of all, I'm going to make some comments based on what was in this paper. FLASH effect is an interesting radiobiological phenomenon. It provides added protection with similar tumor response. The mechanisms are not well understood, although it seems to tie in with radiochemical depletion of oxygen, and there seems to be some kind of an immune modulatory role as well. FLASH occurs at doses that are greater than 10 gray, and therefore, because of these high doses, it's not always suitable. And then, of course, there is a limited availability of appropriate radiation sources. So it's not, the dose rates are difficult to achieve, and therefore we need special radiation sources to get these dose rates. However, the currently available data more than justifies further investigation into FLASH radiotherapy. So my summary of the trends in radiation oncology, some of which are not based on the things that I've talked about, but what I've been observing, we are seeing more hybrid technologies, like we see a combination of a magnetic resonance imager and a LINAC. And we've in previous years, we've seen that combination of a LINAC with CT scanning and cone beam CT. More automation and the use of artificial intelligence. More turnkey installations. So what that means is that machines are coming pre-commissioned from the vendors, and it's much easier to commission the machine in the clinic because it is pre-commissioned, and it only takes a shorter time. It's now weeks instead of months to commission some of the new radiation therapy technologies. There'll be a reduction in the use of planning target volume because of things like robust optimization. There is an increased emphasis on cost considerations because all these new technologies are costing significantly more than the older technologies. There is also a growing concern about regulatory issues. So there's an increased regulatory oversight. We're seeing an increased use of particle therapy. There's many more clinics in recent years that are using particle therapy, like protons and carbon ions. There's an increased use of radiobiological models for treatment planning. So instead of just getting dose distributions, we're now getting distributions that tie in with the use of the radiobiological limits and the radiobiological concepts. Radiomics applications in radiation oncology, and I haven't talked about radiomics at all. I believe there's a lecture in the Brazil course for radiomics as well, which uses information from imaging to enhance interpretation and application of tumor information. And we're going to be seeing more of a clinical implementation of FLASH radiotherapy, assuming that all the research continues to pan out the way it has been. I want to make one comment about references that relate to the use of these technologies, and that is the International Atomic Energy Agency's Human Health Campus. This is a website that has all sorts of resources for learning for health professionals. And you can see here that the Human Health Campus has information for nuclear medicine, radiopharmacy, radiation oncology, medical physics, technologists, and nutrition. And here I've got the radiation oncology component of the website. making the case for radiotherapy in your country, setting up a radiotherapy department, treating patients, training, radiation biology, improving the quality of service, radiation oncology research. There's a library of resources, a collection of recorded radiotherapy seminars, and then there's information about conferences as well. And then for medical physics, again, we see radiotherapy, diagnostic radiology, nuclear medicine, information for medical physicists, training events. There's an e-learning module, International Medical Physics Certification Board, and IAEA references. And there's all sorts of documents and publications that are produced by the International Atomic Energy Agency. Those reports are all freely available. They're downloadable and readily accessible. And so if you have not had a chance to look at this, all sorts of resources are available. So by way of closing, I'd like to quote from Jerome Powell: "We live in a world defined by the rapid pace of technological change." And this is certainly the case in radiation oncology, where the technology of radiation oncology has increased at a significant pace over the last decades and seems to continue to be evolving at an ever-increasing pace. So I thank you very much for your listening and participation, and I wish you the best in your future directions. Thank you.
Many thanks, Jake, for the valuable information you just provided. And I can see through the first 3 to 4 slides that you've made a very marked and significant contribution to the medical physics community as a whole, and radiation oncology in particular. So we are reaching to the point where you can add something if you want, or comment on, and after that we will go to the audience to receive their question, if you don't mind.
Well, that's fine. Thank you very much. Yes, it's been enjoyable to have been involved in the production of these volumes on the modern technology of radiation oncology. As part of developing those books, I learned a lot myself. Because the work was done. The work was done by the authors who I asked to contribute chapters. So there's a lot of information from the contributing authors that are of significant interest. And then I mentioned this other book. I see you put this picture up. That is it came out in June of last year. And that's been an interesting project as well. I already introduced it a bit before, so I won't say much about it. But these are authors from well-experienced and award-winning medical physicists who told stories about their careers. Certainly very interesting to read their stories and to learn from them, because there's a lot of lessons to be learned from people with that kind of experience. Anyway, I'm not going to add much to the lecture itself. There's a lot more that could be said. I've mentioned already in the lecture that I recorded this because it's also being given as part of the course in Brazil. And Brazil is giving a series of lectures based on chapters of the Modern Technology of Radiation Oncology, Volume 4. And the lecturers are chapter authors from those chapters. And so because they asked us to record them, I thought, well, we can use the same lecture for this program of webinars as well. So that's why I mentioned that course. And so hopefully, eventually, you might be able to get a hold of those lectures as well for your webinar program here. So I'll leave it at that. You can, are there questions? I see somebody's got their hand up.
Yeah, Hamza possibly would manage this. Dr. Hamza.
Yes, Doctor. Yes.
Hi, Dr. Dyke, Van Dyke.
Yes.
Well, thank you for this precious information. And actually, I'm a big fan of your papers. You are a great medical physicist. Your papers is so informative, actually. I'd like to ask you about the pointed to thing that you are mentioned about using deep learning for calculating the shifting in doses. So how would you use it? Do you make an algorithm inside the TPS calculations, or how you can do this calculations?
So I missed a little bit of your question because some of the sound went out, but you're asking about deep learning for contouring?
Yes.
Okay, so that is work that is being done well by various groups now. But basically the process is gathering data from different radiation oncologists. So in other words, you get multiple radiation oncologists who outline their target volumes, let's say for prostate cancer. And that data is then accumulated. And a deep learning algorithm is used to sort and to accumulate that data. And that then is in turn applied to developing contours from other images. So it's a process of many radiation oncologists doing this and then accumulating the data using a deep learning algorithm, and then allowing that information to be used for generating contours. So now you say that it means that you don't, in the future, you don't have to do that in individual departments. Although you could use it if you want to keep teaching the algorithm to gather based on additional data. So but the idea is that people around the world would be able to use it not necessarily have to contribute their own data to it. It's already been accumulated and validated. So in a sense, as deep learning algorithms go, you can keep gathering information, you can keep gathering data, you can keep improving the algorithm by this additional information. The challenge is to make sure that everybody is using the same terminology, using the same definitions of target volume, and are using, you know, the same definitions for the stage of the patient and so on, because it's important that all the patient-related parameters are consistent. In other words, you can't use a target volume definition algorithm for a stage 1 prostate cancer, and perhaps not in the same way as a stage 4 prostate cancer, because they're going to have different clinical target volumes. So there is an important component of gathering good data, and that is the real challenge with a deep learning algorithm, is the input data, and is it consistent, and are they using the same terminology, are they using the same definitions? So I hope that answers what you're asking. Let me know if you have any further questions on that.
Thanks a lot for this information. My second question about the complexity. How you in your centers, how you measure the complexity of a plan? Is it using the McNiven complexity score, modulation complexity score? You mentioned complexity of a plan, of plans.
Okay, your voice is breaking up a little bit over the internet, but you're asking about the complexity of a plan.
Yeah, how you can measure it in your plan. Do you use a special algorithm, a special equation, All I know is about the complexity score that is proposed by McNiven, or that name. She proposed a complexity score for IMRT plans in 2010.
Yeah, so I don't have a definition for complexity of a plan. I think you have to look at the literature for that, and you're referring to a good reference there. But basically, it takes into account the various parameters that are associated with numbers of beams and multi-leaf collimator shapes and so on. So I really don't have a good answer for you. It's not an area that I've been involved with. But I can imagine the complexity of a plan is defined by the numbers of directions and the numbers of multi-leaf collimator positions and so on.
Okay, thank you. That's really great. Thank you a lot.
Okay.
Okay, now we have three of the audience raising their hands. We will start with Dr. Alauddin Al-Asadi, please.
Yeah, thank you. Hello, Dr. Jack. This is Alauddin.
Yeah, hello.
Hi, how are you? Good. I want to thank you for accepting this invitation and sharing your knowledge with the IMPS members. Actually, I have two questions regarding flash therapy. First, with the flash therapy, the dose rate is approximately 500 times greater than that of conventional radiotherapy. My first question is, does the flash therapy have a higher dose rate but lower fractionation? In other words, the total dose delivered will be equivalent to that of conventional radiotherapy. And
so the flash effect seems to require a higher dose per fraction. So far, they've been looking at doses per fraction that are about 10 gray. So conventional fractionation, we're talking about 2 gray per fraction. For flash, they are talking about 10 gray per fraction to have the flash effect actually occur. So what it does mean is that flashed radiotherapy will require fewer fractions, but higher doses per fraction. And how much variation that is from conventional doses, I think, is still to be learned. But probably compared to a conventional 2 gray per fraction treatment, it'll probably be less than that for flash because it's basically a hypofractionated course of treatment. So if you think of prostate getting 70 gray in 35 fractions, flash might be and I'm not quoting real numbers here because we don't know what it is yet, but it might be like 40 gray in 4 fractions, where each fraction is 10 gray. So the likelihood is that the total doses will be lower than the conventional fractionation doses, and it'll be like a hypofractionated course of treatment.
yeah, thank you. I have another question, please. My second question is, given that the 4 R's, that mean repair, repopulation, and redistribution and reoxygenation, occur in or at different dose rate, the question is, how can the flash effect explain how the cell survival?
Well, that's a great question. And that's a question that's under investigation. The mechanism for the flash effect is not very well understood. It has been tied in with oxygenation and the impact of rapid dose delivery and how that impacts oxygenation and the impact of oxygen. But it's not well understood, and those are research questions that are presently being investigated, and that's been one of the concerns about how far is this going to go. We don't really understand the mechanism. So far we do know that it needs a fairly high dose per fraction, which impacts sort of issues related to conventional fractionation procedures. And yes, that is an area of research that I think may take some years to sort out.
Yeah, thank you. Thank you very much.
Thank you to Dr. Alauddin Al-Asadi. Now we shift to Safa Al-Qaisi.
Hello, Professor Jake.
Hello.
First of all, I would like to thank you for your for being with us today in this presentation and for your valuable information you shared with us today. And my question is about the MR Linac. What makes the patients a good candidate for the MR Linac, or the criteria like make the patient is a good candidate for treating on the MR Linac machine?
So my first comment would be, it would be those patients that that require precision radiation therapy. So by precision, I mean that we want to minimize the target volumes and minimize the dose to normal tissues. And so these are probably fairly early stage cancers or cancers with well-defined tumor volumes. Because the benefit of an MR Linac is that you can give the dose delivery with a high precision, and you can adapt the treatments accordingly. So the example that I showed was prostate cancer, and for shifting from a 4 millimeter margin on CT on a conventional Linac with CT. With cone beam CT guidance and using a 2 millimeter margin on a prostate cancer patient with MR guidance made a significant difference to normal tissue toxicity. And so it's those kinds of patients, wherever you have a well-defined target volume, where you can minimize the margin between the clinical target volume and the planning target volume. Those are the patients that are most likely to benefit from the MR Linac.
Sounds good. Thank you very much for your answer.
Okay.
Thanks to Safa. Now we shift to the last one, Tabarak Al-Salmani, which raised her hand.
Hi. Thanks for this nice talk. And I have a few questions, if you don't mind, and a comment. The first question that I have, that for tumors that are treated with MRI guided radiotherapy. So what type of tumors? You mentioned the prostate, okay? But what type of tumors specifically that are good represented to be, to get the benefit of MRI guided radiotherapy?
Yeah, that question is similar to the one that I just answered, and it's really those tumors that are reasonably well defined, and for which we can reduce the margin between the clinical target volume and the planning target volume. So if we can reduce the margin, then we're going to irradiate less normal tissues, and with that, we should be able to have less complications. And prostate was one example. I can imagine some head and neck tumors might be an example. If we can control the breathing motion, which they can do that now on the MR Linac as well, then lung tumors may be a good example of that as well. If we can, improve our setups for breast cancer treatments, then that may be another example. I think there's a possibility of a wide range of tumors that may benefit from this kind of treatment, but it's really those treatments where we can actually reduce the margin, allowing for uncertainties in setups.
Okay.
And that's really where the potential gain is going to be.
Okay, but if like the patient will be staying at the treatment for long, as you mentioned in the presentation, for around, let's say, 50 minutes. Okay,
Right.
Wouldn't that result in a higher dose to the other organs, or to increase the toxicity that so,
Well, it gives the opportunity for more motion.
okay, yeah.
But if you are able to watch this and observe it via the MR imaging, then
Yeah.
that's not likely to be an issue. So you can excuse me, you can gate the treatment such that especially if you're doing the thoracic region and you're counting for breathing, that
Yeah.
you only have the beam on under a certain point when the tumor is in certain positions, then that it does enhance the treatment time, but you're improving you're reducing the normal tissue irradiated. So there is that benefit. Even though it takes longer, you're still better off because you're controlling how the dose is delivered.
Okay, that's nice. Thank you. And another question, actually, it's not a real question, but I'm asking for the MRI guided and the flash radiotherapy. Can I get some protocols for or that are published to regulate the for the acceptance commissioning and to help in decision making and these stuff?
That's a good question. My comment would be you should connect with the developers of the MR Linac and or anybody that's already installed such a system. We have a couple that have been installed in Canada. There's a number that have been installed in the US. And I suspect that some of these clinics will have their implementation commissioning protocols. And perhaps it's even available from the vendors. So ViewRay or Electa should have some of those protocols available. So if you're seriously interested in an MR Linac, then I would begin by contacting the vendors and getting their advice.
Yeah, that's good. Okay, thank you. And as a comment for what Aladdin, the second question of Aladdin, I read that the one explanation for the rationale behind the flash radiotherapy is that it is stimulating the immune system.
Yes.
So yeah, and that it helps that the immunology system that attack the tumor itself, and helps that to the tumor shrinkage within a few days after the radiotherapy.
Yeah, that is correct. I mentioned that in one of the points on my slide as well. That there's the sort of the oxygen considerations, and there's immunotherapy.
Yeah.
Immune response considerations. Again, both of those mechanisms are not really well understood, and they have not been well quantitated. The immune response might be the part that also impacts tumor control, so that it improves tumor control in addition to reducing normal tissue toxicity.
Okay, thank you.
Yeah, good.
So thanks to the audience. Now we shift to Prof. Hussein.
Okay, many thanks for all those people who asked their questions. And I think the president of Iraqi Medical Physics Society want to comment or to add something. Dr. Mustafa, it's yours.
Thank you, Prof. Hussein. Thank you very much, Prof. Jack, for this wonderful presentation. It was a very valuable and important lecture. We hope that it will be repeated in another lectures. And
Yeah.
we also hope to do cooperation programs in this specialization, medical physics. We also extend our sincere thanks to Dr. Alauddin for providing this good and useful opportunity. Thank you so much, Prof. Jack.
Mhm.
Thank you. It's been my pleasure.
Many thanks, Dr. Mustafa, for your comments. Jake, it looks that we are reaching to the end. And on behalf of Iraqi Medical Physics Society, I'd like to thank you very much for being part of our scientific event tonight. Hope, as Dr. Mustafa said, we can have you again in another time where it's possible to have some more information about radiation oncology. Many thanks. It's well appreciated.
You're quite welcome.
Many thanks. Many thanks.
Okay, bye now.
Okay,
So-
bye. Bye.
Bye. Bye.
Thank you, audience.
Thank you so much.
Thank you. Bye.